Welcome, everyone. We are so excited to be able to have our guest speaker on endometriosis today. If anyone has any questions, feel free to put it in the chat on the Zoom. There's also going to be a rerun posted on our Facebook page, and you'll have the opportunity to drop your questions in the comments. And at the end of the month, a couple of our therapists will be there to answer any of your questions, as well as at the end of our interview today. So, without further ado, I would like our guest speaker to introduce herself before we start.
Sure. Hi, I'm Iris Kerin Orbuch, Dr. Orbuch. And first of all, thank you for having me on, helping to spread awareness about endometriosis. By profession, I'm a doctor who loves to excise endo, which is the proper treatment of endo, and that's what I'm fellowship trained in. But my approach is really an East meets West, looking at holistic approach from head to toe, trying to identify all the different generators of pain to really help those who are suffering with endometriosis reclaim their lives, essentially.
Very nice. Thank you, Dr. Orbuch, for joining us today. Our first question, can you just tell us a little bit more about endometriosis?
Sure. So endometriosis is a disease process that affects way too many. They say roughly about 10 to 12% of women are affected with endo, and translates about 200 million women worldwide. And it's a disease that it's like this invisible disease that can cause a whole host of GYN symptoms, such as painful periods, heavy periods, painful sex, pelvic pain that can happen any time of the month, before one's period, after their period, all month long, during ovulation, can cause a whole host of GI symptoms such as constipation, diarrhea, bloating, alternating constipation and diarrhea, urological symptoms such as urinary urgency, frequency, or painful urination. Overall, because it's an inflammatory process, lots of fatigue. And essentially, scientifically, what endo is when you have cells that are similar to the endometrium. The endometrium is the lining of the uterus that every month gets thicker and thicker and thicker, and then we shed our endometrium. So endometriosis is when you have similar cells to the endometrium, but those cells are found outside of the uterus. And what happens on a monthly basis, our hormones that come from our ovaries are stimulating our uterine lining to get thicker and thicker and then shed. And those implants too get thicker and thicker each month, but there's no exit point in the pelvis. So month after month, the implants cause structural abnormalities. It can be honestly found anywhere from head to toe, but let's just talk about the pelvis. It'll pull the uterus or the cervix or their ovaries. It'll structurally move things around. And it also, those implants are pro-inflammatory, and it just sets off body-wide inflammation.
So can you elaborate a little bit more on the different areas? So you had mentioned within the pelvis, we can see a lot of pull of those pelvic organs. Can you elaborate a little bit more on where endo can lie in that abdominopelvic cavity?
Sure. So within the abdominopelvic cavity, endometriosis can be really found anywhere. It can be on your uterus, on your ovaries, on your fallopian tubes, on the peritoneum, which is the saran wrap covering that covers the abdomen and pelvis. It can be on the ureters. It can be on the liver. It can be on the domes of the diaphragm. It can be up into the lungs. It can be on the rectum, by the bladder. It can be found anywhere within the abdomen and the pelvis.
So that sounds pretty widespread in terms of where the endo can lie. Can you tell us a little bit more about what those symptoms might look like with someone who has endometrial tissue?
Yeah. So just to stress, it's endometrial-like tissue. It's a big sticking point because the whole idea of retrograde menstruation which is what I learned about when I was a resident, meaning we were taught that endometriosis is when there's a reflux of the endometrium into the pelvis. That is just not true at all. So endo kind of specialists are really, want everyone to know that it's similar cells to the endometrium. So endometrial-like tissue, because endometriosis does not get its origin from the reflux or retrograde menstruation. We can talk about that afterwards and how it's been found in fetuses. So the symptoms can be, so what's fascinating is that there's no correlation between quantity of endo and severity of symptoms. So someone could have one tiny spot of endo and they can be in debilitating pain, or they can have one spot of endo and they can have no pain. And the converse is true. Someone could have a belly full of endo and be totally asymptomatic. Others can have a belly full of endo and have debilitating pain. So the symptoms that people usually have, it's sort of the GYN symptoms, the GI symptoms. Honestly, I see GI symptoms all the time. The urological symptoms, infertility is huge. Those with unexplained infertility, that means infertility where the sperm is okay, the tubes are open, and imaging doesn't reveal any abnormalities. That's called quote unquote unexplained infertility. Endometriosis is the etiology of like 40 to 50% of unexplained infertility, which is pretty crazy. It's more so, it's like the inflammatory effect of endometriosis, just not allowing the sperm to get to the egg to get to the sperm, or if in fact that they do implant, it can cause miscarriages. So there's a whole host of symptoms. And what I like to honestly shout out from the rooftops, if I could, everyone's endo symptoms are very different. I have many sisters, I have many mother-daughters, and some people's endo symptoms are just constipation, and that's it. They don't have any GYN symptoms. They could have a sibling, the sibling does not have GI symptoms, and they just have GYN symptoms. So I just don't want anyone to compare their symptoms to someone else, because the symptoms can really be very varied amongst different people.
So in terms of the most common age of diagnosis, is there a common age of diagnosis, or do you see this happening throughout the lifetime?
Mm-hmm. Love that question. So endometriosis can be found at any age group. I want to talk about the fetal study that I had just previously mentioned. There was a fascinating study that looked at female fetuses who unfortunately had passed away. Let's say there was a car accident that the mom was in, or for whatever reason, the fetus passed away. A group of docs then took all those female fetuses, they did autopsies on them, and they found that 9% of female fetuses have endometriosis. So 9% is not that dissimilar than to the 10-ish% that we quote today in those who have endometriosis. So endometriosis has its roots, it's definitely passed down from like genetically. And so if it's there from the fetus, very often I see when I take a history, I always go all the way back in my history. And often there are many young girls who suffer from stomach aches, constipation, diarrhea, even prior to the onset of getting her period. The reason being is that those implants are present, they're there. And as we know, we typically develop like axillary underarm hair and pubic hair before we get our period. When we think about like the Tanner stages and like what normal development is in girls. And we have hormones that are released like estrogen and all these different hormones that are released often a couple of years prior to the onset of our periods. So if we have that endometriosis tissue already there from birth in many people, they'll already start with GI symptoms or discomfort or stomach pain or pelvic pain prior to the onset of their periods. I see that all the time. I think most docs just don't go back and ask those questions, but I see that. So teens absolutely can have endometriosis, one of my specialties. And I love treating all my patients, but I love treating teenagers because we're picking them up so early and really avoiding that 10-year delay in diagnosis, which is what we currently run into in the US. So patients typically, on average in the US, see 8 physicians over a course of a decade, over 10 years prior to diagnosis. So, any age group can get endometriosis.
And in
I
terms of,
actually just had a almost 50-year-old who was referred to me, my last patient, and who probably has endometriosis. So I see 12-year-old, 10-year-olds, I see mid-50s, I see 40s, 30s, 20s. What I can say over the last like 16-ish years or so, or 17, I forget when I finished my fellowship, but I used to always see, and the first thing I do when I get into the office, I look at my new consults and I look at the ages. When I think back 10, 15 years ago, it was 39, 42, 45. And now I'm seeing a lot more 20-year-olds and a lot more teenagers. And I think that's because of the advent of social media and just raising awareness.
and I know you talked a little bit about prevalence, that 9 to 10%
Mhm.
that you had brought up. Can you elaborate a little bit more on the prevalence of this disease?
Yeah. So, there's no particular color, race, nationality, location. It affects everyone. Roughly about, they say 10 to 12% of the population. And what we do know also is exposure to dioxins. Dioxins are released as byproducts of bleaching. So we do know if there's a mom who's pregnant, that fetus inside her, if the mom didn't have endo, those dioxins can then cause endometriosis in that fetus. So there's probably many other chemical toxins that we don't know of yet that can cause endometriosis. But we certainly know that it affects worldwide about 10 to 12% of women.
And in terms of what are the cardinal signs that a patient and her doctor should seriously consider endo as a cause of her pain, can you share a little bit more about that?
Sure. So the question is, lots of times I give a lecture and one of the titles that I had for a lecture was Endometriosis Hidden in Plain Sight. Because most gynecologists are not equipped with knowing the right questions to ask to ascertain whether someone has endometriosis. So if we know the right questions to ask, a gynecologist would be able to have a really high index of suspicion whether their patient has endometriosis. So if the gynecologist or the internist or the pediatrician or the GI basically asks, do you have painful periods? Do you have heavy periods? Do you have pelvic pain any time of the month? Do you have constipation, diarrhea, bloating, painful bowel movement, any urinary urgency, frequency, or painful urination, fatigue, or any infertility issues? If they ask all of those questions, they should have a high index of suspicion. Teenagers in particular, there was one study that looked at teenagers, and if they have really painful periods, 70% of those teens have endometriosis. So if you can imagine way back, even a teenager, really bad periods, 70% likelihood you have endometriosis. Already as a teenager, roughly 50% of teens already have a GI symptom, and roughly 50% of teens already have a urological symptom. So that's me taking my history. I take about an hour and a half intake on my first initial consult with patients, trying to get a history from, I always say, start way back at the beginning and then bring me to today. And then my physical exam for me, after I usually read all the records that are sent to me prior to a patient coming into my office, and I listen very well. And then my physical exam took me a long time to learn the proper exam in order to diagnose. I'm trying to figure out on my exam all the different reasons for pain, because if you can imagine that there is a 10-year diagnostic delay, there's all these coexisting conditions, and including endometriosis, that patients typically suffer from. We'll talk about pelvic floor tight muscles first and foremost, because if a young teen is having painful periods, they're going to be assuming this closed, squeezing fetal position like this. Already their abdominal muscles are tightening. They're kind of squeezing their whole pelvis. So on my physical exam, essentially what I see is when I first do an abdominal exam, and I can appreciate really tight muscles, tight diaphragm. And then from a vaginal exam, typically, if this is the vagina, the cervix should be right in the center. I usually find the cervix pulled over to the right or to the left. And that's usually because the uterus sacral ligaments are infiltrated with endometriosis. And then when I push on those uterus sacral ligaments, if it reproduces pain, I typically know that they probably have endometriosis. And I can tell them with a 90% likelihood right then and there that they have probably have endometriosis. Yeah.
So in terms of, so before we go into specific treatments, can you just give us a broad idea as to what's out there for patients and how we go about specific treatments within that umbrella?
Are you talking about what's out there? Do you mean from evaluation or from a treatment perspective, or
From a treatment perspective.
treatment perspective? Okay. So the gold standard treatment to treat endometriosis is surgical excision of endometriosis. Excision literally means to cut out the endometriosis. But let's take a step back. Okay. I look at it as there's medical treatment, there's surgical treatment. What's important to know is all the medical treatments don't stop progression of endometriosis, don't cure endometriosis. All the medical treatments, which I'll go over in just a moment, just treat the symptoms of endometriosis. So if you have really painful periods, maybe it will lessen the pain. If you have very heavy bleeding, maybe it'll lessen the heavy bleeding. If you have any GYN symptoms, let's say, it may lessen them. So from a medical perspective, let's say birth control, that's probably go-to number one. You could go on the pill. Let's say you have, as a teenager, you get your period at 13. It's debilitating. Even if you went on the pill the first month after your first debilitating period, and maybe the mom was clued in because the mom has endo and the aunt has endo, and the mom put the young teen on birth control. If I did a laparoscopy even a couple of years later, I could see advanced endometriosis, like stage 3, stage 4 endometriosis, meaning higher stage, more endo. So, the medical treatment, birth control is the most prescribed just to treat the symptoms. Then there's other medical treatments. I am not fans of them at all. They are the GnRH agonist and antagonist. And unfortunately, they're being prescribed way too often now. But those have side effects of hot flashes, weight gain, joint pains, muscle aches, osteopenia, osteoporosis, depression, and the newer medicine has suicide. And one of the newer medicines, literally, if you have painful sex, deep positional painful sex, the package insert for Alyssa says you can't take this medicine for more than 6 months. So I'm getting all of these patients who were put on these medicines by their generalists who think that these medical treatments treat and cure endo. They do not. They just treat symptoms. They're coming into my office. So on top of feeling miserable for their endo, they now have hot flashes, weight gain, joint pains. They're more fatigued. Their bones are thin. And then they go off of these medicines and they still have those symptoms plus their endo symptoms, they're like, why in the world did my gynecologist put me on these medicines? I feel worse now than I did before. So the medical treatments really do not do anything but treat symptoms. Surgically is how we make the diagnosis of endometriosis. Endometriosis can have a lot of varying appearances. It can have a lot of different looks at the time of laparoscopy. And I always tell my patients that in my first week of fellowship, I learned more about endo than I did in 4 years of general OBGYN training, which means most general OBGYNs out there, I was one of them, did not know and do not know much about endometriosis. So I learned as a OBGYN resident 2 appearances of endometriosis. That's a powder burn lesion and a chocolate cyst. Week 1 of my fellowship, I remember my amazing mentors showed me, this is endo, that's endo, that's endo, that's endo. And I was like literally chin down to here. Oh my gosh, really? Really? I didn't know that, because endo can be blue, it can be red. In teens, it can be clear. It can be a conglomeration of blood vessels. It can be brown. It can be pockets in the peritoneum. It has all these different appearances. So what happens is, if a generalist is someone who does obstetrics and gynecology, if they're taking you to surgery to look for endo, many of them are missing endometriosis because they don't know what to look for. And 2, they're doing the wrong surgery. They're doing ablation or burning of endo. So let's say like my fingernail is a whole endometriosis implant. Excision will excise the whole fingernail, let's say, whereas ablation will just get the tip of the white part of my fingernail and leave the rest of the implant behind. You have to remember that that implant is structurally pulling the endo, and that inflammation, that inflammatory stuff is still there, leading to head to toe inflammation. So it's crazy. It takes nearly a decade to get the diagnosis, but then most of those who are having surgery are having the wrong surgery. So what one wants, the cornerstone to treating endo, is surgical excision of endometriosis.
So in terms of the surgical excision, when one goes through an excision surgery, do people ever go through multiple throughout their course of endo, or is one usually enough?
So if you're with an excision specialist, I would say most of us would say our reoperation rate is 5%, 5 to 10%. Now, it depends at what age you're doing the first surgery, okay? Because if you're operating on a teenager, they have, 30 more years until they go into menopause or so, as opposed to if you're operating on someone like in their 30s, they have 20 more years. And there could be microscopic endometriosis, but it's rare that we do reoperations on patients. The highest likelihood of reoperations are the following 2 scenarios. One is someone's desirous of fertility, where we go in and we operate, we excise endometriosis, and then we also see that maybe there's extensive adenomyosis. Adenomyosis is when you can have endometriosis in the muscle of the uterus, but for preservation of fertility, we don't want to address the uterus. So then we go back, and if they're still symptomatic after completing childbearing, then we do another surgery. And let me say, not everyone with adenomyosis is symptomatic from adenomyosis, okay? And number 2, those with endometriomas, those are cysts of endometriosis in the ovary, they have a very high likelihood of having recurrence. Like in my hands, it's about 40% or 50%. I think in a general gynecology practice, it's close to probably about 100% reoccurrence. So, but typically the reoperation rate is pretty low.
So in terms of when you get the excision surgery and following, are there hormonal drivers that cause someone to be more susceptible for the return of tissue growth after that? Or what are the types of things that you work with patients to prevent the endometriosis from returning?
returning. So it's a good question. I think honestly, number one is good surgical technique, meaning excising all the endo and proper excision, because there's a lot of docs out there who say they're doing quote unquote excision surgery. And then I read the operative report and they do one excisional biopsy and the rest is ablated. So we really, if you're taking someone who has really good excision and we really keep the inflammation down in their body, and I do that by the gut, I revamp the gut, I evaluate for a bacterial overgrowth. I try and encourage people to eat, organic, dairy-free, gluten-free, because those are pro-inflammatory. I really find that decreasing inflammation in one's life, whether it's, like a sanitizer or a lotion or a shampoo, all these things are going into our body. If they're pro-inflammatory, it can then set off an inflammatory state. I'm not saying shampoo is causing endo. That's not what I'm saying. But I'm saying, even if we have some endo, that maybe new growth endometriosis, as I mentioned, there's no correlation between quantity of endo and severity of symptoms. So if we're feeding our body McDonald's and Big Macs and pro-inflammatory food, and our whole environment is pro-inflammatory, yes, that inflammation is going to feed those inflammatory implants. Okay, so we want to assess, keep our environment, our gut, our diet, what we're eating. I don't like the word diet, but like what we're eating really clean, and then also assess for all other pain generators, because there's a lot of other things that mimic endo pain. One is pelvic floor tight muscles. And I always get my patients into pelvic floor PT prior to going into surgery and then continuing after. There is painful bladder syndrome or interstitial cystitis, which is known as endo's evil twin. So all the symptoms that I had mentioned at the beginning can also be ascribed to interstitial cystitis. And there's many other things that can cause discomfort. Like for instance, I know in my practice from Thanksgiving to Christmas, that's when, maybe not this year because of COVID, but in the past, people are going to holiday parties, drinking a lot, eating more fried foods, sleeping less. There's stresses with the holidays. I would often get patients coming back and saying, my endo's back. And I would say, like, what are you eating? What are you drinking? And it's actually their interstitial cystitis that is like giving them the symptoms similar to endometriosis. And once I get them on low acid, low potassium, stop the alcohol, give them adequate sleep, and kind of revamp their lifestyle, they're like, oh my gosh, I'm so much better.
So in terms of your experience with women who have been going through, so they got the excision surgery and then these lifestyle modifications that you just mentioned, can you elaborate a little bit more on these lifestyle modifications when it comes to
Sure.
sleep, diet, all of that, as a way to not only manage inflammation prior to surgery as well as after, or for those who are just not getting surgery for their endo?
Yeah, absolutely. And that's what so in like 2000, I'm trying to remember, it was somewhere between 2003 and 2005. It was when I was a resident into my fellowship. I read this paper that there was no correlation between quantity of endo and severity of symptoms. It was just kind of stuck in the back of my head. Okay. And I've spent all the time since I finished my fellowship trying to better understand why is that. And I used to think that endo, we excise it, we cut it out, and that's all there is to endo. And now my view of what endo is totally different. Yes, we need to excise and cut out the endo, but we also have to look at the inflammatory component of those implants and what the inflammation is doing to the central nervous system and accruing all these other pain generators. So first thing I do when a patient comes to me is I take a really extensive history and I listen, and I really listen a lot to how they describe their symptoms. and I'm trying to evaluate for pelvic floor tight muscles, interstitial cystitis, a bacterial overgrowth. Do they have celiac? Do they have hernias? Do they have central sensitization, which is a flared central nervous system? Do they have all these other things? And then I examine them, and my physical exam is quite thorough. I can really ascertain and break down all of these different things that they do have. So whereas in the past, when I first finished my fellowship, I would jump in and operate very quickly. Now I'm so different in how I practice. I first try and undo as many of the coexisting conditions that one has. First off, for me, is I get them into pelvic floor physical therapy. And I try and teach them proper bowel habits, get them to buy a squatty potty, get them to meditate, get them to be mindful, get them to start eating in a healthy way, trying to sleep in a healthy way. If they have anxiety or depression, really encouraging them to talk to someone, because anything that comes from our anxiety and depression revs up the central nervous system. And then what that does, that then sends messages down to the endometriosis, and it worsens the endo pain because everything is modulated by the central nervous system. And anyone who's anxious, I'd be anxious and depressed if I went and saw 8 doctors over the course of a decade until I was diagnosed. So if I'm anxious or depressed, I'd be assuming a tight position like this. I'd be then tightening my pelvic floor muscles even more, revving up more and more pain. So I have my patients, it depends, I really individualize care. So I'm looking for all of that. We revamp their gut, boost their gut. We work with integrative nutritionists. Some we work with integrative internists or naturopaths or acupuncturists. I address traumas. I kind of look at the whole body. Then when it's the right time for that person, we do surgery. It's different for everybody. And, I really am finding, and I always ask patients going into surgery, from our first visit till pre-surgery, what % better is your pain? And the numbers I'm hearing nowadays by employing skilled pelvic floor physical therapists, addressing the gut, addressing the mind and body, and addressing their bladder, I'm hearing 30 to 70% better all the time. They're 30 to 70% better before I touch them surgically. We have to surgically operate on them, because if we don't excise and remove the endo implants that are pulling the muscles like this, that are setting off inflammation, we'll just never get them out of all this multimodal therapy. So I kind of down-regulate them, operate, and then I have them continue all of this stuff. Everyone's different how long we need to continue for. I do at minimum have them continue for 3 months, because it does take a full 3 months for healing. Other people need to be in PT for a year or 2 years or 3 years. Other people, the gut, it takes time. Everyone's different how long it takes, but I always down-regulate prior, do a good surgical excision, continue to down-regulate and address different aspects. And that's why I wrote my book, Beating Endo, How to Reclaim Your Life from Endometriosis, because when a patient comes to me, endometriosis is the primary limiting factor in that patient from really living their life to the fullest. It's like the endo, they're planning their schedule. Oh, I'm gonna have my period then. Oh, my pain starts 8 days before my period. I can't have that meeting then. Oh, my period lasts for 7 days. I can't have it then. Oh my gosh, I'm ovulating then. I can't. Like, all of a sudden they have like 4 good days a month that they can actually feel well. So I want them, my whole goal is to have them reclaim their life, meaning like be able to do what they want to do, live their lives to their fullest. And the only way that I've figured out how to do that is really an East meets West approach with surgical excision at its cornerstone.
So in terms of people's options for surgical excision specialists, are there quite a bit throughout the country, or because in terms of options that people have, you had mentioned excision versus ablation. Are
Mhm.
more people in terms of the surgical treatment, are more people getting trained in the excision? Are we seeing more ablation throughout the
So,
country?
so thankfully, well, they say that there's less than 100, I think, in the country, which is, I mean, that's, if there's, are there 50 states? That means like 2 per state, which is scary, right? Forget how many billions of people live in the United States. You can't have 100 doctors treat if half of those are women. I mean, there's not enough excision specialists to treat all of those 10% of women, right? So, but thankfully there's more and more. We just came off the Endometriosis Summit, which was this weekend, which is a multidisciplinary approach, multidisciplinary meeting, which is really bringing together physical therapists, integrative pain docs, physiatrists, gynecologists, surgeons, and patients together in order to make greater and greater, and fertility doctors, greater inroads into assessing the needs of all the patients. So I definitely see it going in the right direction, but no, there's certainly not enough excision doctors out there.
And in terms of experiencing endo, you had mentioned how the amount of tissue doesn't always equate to what types of symptoms that people have.
Mm-hmm.
Are there individuals that can successfully be empowered throughout their journey without having surgery?
So, I have different patients at different times who either don't have the time to have surgery, or everyone's different. Typically, most people end up having surgery at some point. I have some people who just say, I'm in college, I'm working to pay my tuition. Right now, I just need to focus on eating healthy, going to pelvic floor PT. I got to get through college. And then once they start a career, then they save up for surgery. And ultimately, at some point, most people have surgery. It doesn't have to be at the beginning, and I don't push anyone towards surgery. But if you understand that endo is A, structural, and B, causes an inflammatory response, if there's a structural component, it's pulling the organs one way. And what's happening is the underlying muscles and fascia are being pulled. So like the patients will get better, but then they're going to plateau until we excise that and then restore the anatomy. Does that make sense? So certain things may take the edge off, but like you'll have to continue employing them. So most people end up having surgery at some point, but I never push anyone into surgery. Even though I love to operate, I don't push anyone into surgery.
Got it. And in terms of the standard of care for post-op recovery, can you elaborate a little bit more on that?
So there's standards of care. Then I do things very different. I do things different than I think just about every doc out there, because I really believe in a multimodal approach. So I have my patients go back to PT within a week and then continue. Most of my patients have already been healing their gut with supplements, or they're treating their SIBO herbally, I have them go back on that. If they are on a low acid, low potassium eating, they've been on that going into surgery, and certainly they're continuing. If they're working with, if they've been meditating, I have them continue to meditate. Whatever they've been doing before, I have them continue. And I always tell them, my surgery doesn't treat pelvic floor tight muscles. Pelvic floor PT fixes tight muscles. My surgery doesn't fix painful bladder syndrome or interstitial cystitis. There's a whole nother modality for that. Meaning we have to treat all these different things, but mine's gonna restore the anatomy and cut out the inflammation and cut out those implants. That's gonna allow everything to work better. So most of my patients don't even take narcotics after surgery. And if they do, they maybe take one the first night. It's because I'm down regulating their pain going into surgery. When I think back to how is my practice different, when I came out of fellowship, I used to write a prescription. My patients used to take tons of narcotics. But now, because I'm doing it so differently, and I understand, because I've been on this quest, why is there no correlation between quantity of endo and severity of symptoms? And I really think because the way your central nervous system's responding, and because there's all these coexisting things worsening pain, if we can identify and treat all of those going into surgery, and then do a really solid, great excision surgery, my patients usually just use Motrin and Tylenol for 2 days or 3 days. Very different than all the narcotics that were used when all I did was just excise.
So you had mentioned a few things about the central nervous system, and as pelvic floor PTs, we do a lot with the nervous system, soft tissue and all of that. Can you share with us a little bit more on how endometriosis affects the central nervous system and what that might look like, not only post-op, but also pre-op and then follow-up post-op?
Yeah, so there was great studies by Pam Stratton. I'm blanking on the other author. It'll come to me. But what they looked at, like, let's say, I'm just looking for something on my desk. Okay, let's say this is an endo implant, okay? What they found is that there are nerves that go from the implant to the central nervous system. Over time, there's an increase in nerve density. Whereas if there was one nerve going from the implant to the central nervous system, over time there's 2, 3, 10, 20. There's an increase in nerve density. And so the longer someone goes from symptom onset to diagnosis, there's a higher nerve density. And what we know, it's not only excising that implant. Okay, yes, that's going to stop more and more nerves from being created going to the central nervous system. But now those nerves that were firing fire on their own, essentially. That's what central sensitization is. It's a flared central nervous system. And the central nervous system is just firing and firing on its own. And the way that I explain it that makes it like tangible is I explain it as following. Like, let's say a little kid sees a burning hot stove and he or she wants to put their hand on the hot stove because it looks so enticing, right? They put their hand on the hot stove, the message goes up their arm to their spinal cord, it's interpreted by their brain, and the message goes back down to their hand. Okay, it's boom, split. They lifted their hand off a hot stove, maybe the skin will slough off, it'll hurt for about a month. Kids never going to touch a hand on that red hot stove again. That's what we call an acute injury, right? Endo is chronic, a chronic hand on a hot stove, basically from a teenager or whenever the pain starts. Let's say I get a 30-year-old in my office, they basically have a hand on a hot stove going ouch, 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 ouch for 10, 15, 20 years. So that endo is causing a flared central nervous system. The tight muscles that ensued from this fetal position or being constipated and sitting on the toilet for a half an hour trying to push out stool, tight muscles are another hand on a hot stove, okay, going ouch, ouch, ouch. If they have a bacterial overgrowth, that's another hand on a hot stove going ouch, ouch, ouch. If they have painful bladder syndrome, that's another hand on a hot stove going ouch, ouch, ouch. And so what we need to do is lift up all the hands on a hot stove, but we also have to treat this central nervous system that's firing on its own. So that's what the central sensitization is. I always start with breathing techniques and meditation and mindfulness, but some patients need different medicines to downregulate their central nervous system. I individualize my treatment for everyone.
Absolutely. And I think that it's so important to consider that every patient presents differently, will respond differently to different treatments. And from a pelvic floor physical therapy standpoint, with what you were saying with those tight muscles being one of those pain generators, our goals at Pelvic Floor PT is to take and first identify those muscles that could be part of your pain generators and retraining those tissues to reestablish mobility, to behave and move and glide and slide like the tissues around your body. Like my arm, when I sink my finger into my hand, my tissues move with me as opposed to combating against my pressure. And so
Mhm.
a lot of what we do at Pelvic Floor PT is tissue retraining and trying to retrain those muscles in the abdominal wall and the pelvic floor to be able to move, glide, and slide just like the tissues, let's say, on your arm, and restore that function there. Anything else, Dr. Orbuch, that you want to add and share with regards to endometriosis before we answer questions?
That's such a great example that you use, just with the hand in terms of the pelvis. I like that. I just want people, those who are suffering, to know that there's not alone. There's a lot of great support groups out there. I really encourage those. There's a documentary out there called Endo What that you can watch on endowhat.com. The Endo Summit, which was the last couple of days, I think you can watch it for the next 10 months. There's so much information on the Endo Summit. There's different support groups. I love Nancy's Nook. Nancy's Nook has, I forgot how many members, so many members, but it's a online self-directed support group. So you can ask questions. There's tons of information out there. Just to know that you're not alone. And just because it's invisible, right? That if you don't feel well, to really find a doctor who can help understand your symptoms and to get you better. I think the documentary really helps validating pain, because I hear it day after day, patients saying, my last patient, she's like, I've been going to doctors for years and they're telling me there's nothing wrong with me. It's because we don't see endo on blood tests and imaging. As physicians, we're taught now you have 8 minutes to figure out what's wrong with the patient. And let's just order a test to show us what's wrong. You know, we don't think anymore as doctors. We need to listen to patients, right? And we need to know what questions to ask. So just to know that you're not alone is something that I really want to share.
Absolutely. In the chat box, Dr. Orbuch, if you can look over there to see if we can answer any of these questions.
Sure. Let me just put my glasses on and see. I had an appointment. They talked a lot of debulking, didn't use the word excision, just hysterectomy. Okay, this is very important to know. Okay, so it is a myth. So hysterectomy, let's break the word down. Hyster means uterus, ectomy means to remove. Hysterectomy means removing your uterus. Hysterectomy is not the treatment of endometriosis. I was taught that in residency. So all the general gynecologists who don't know what endo looks like, don't know about endometriosis, they're taught the wrong thing. Why would it make sense to remove a uterus when endo by definition is external or outside the uterus? So if you're getting the same growth on your rectum, bladder, cul-de-sac, because it was not excised, it was ablated, I wouldn't go in and have another surgery where they remove your uterus, because they're going to leave all that endo behind. You need to find an excisionist who's going to cut out those implants. The only reason to have a hysterectomy is if there's endo in the muscle of the uterus. That's known as adenomyosis. So you need to point blank and ask your doc, hey, do you excise endo? If it's the same doctor who you went to for those other 2 surgeries, clearly they're just going to ablate again. So definitely find an excision surgeon. On my rectum, only ablation. So the next one, I would recommend people going to Nancy's Nook. On Nancy's Nook, it's a Facebook group, and she has doctors all across the country who perform excision of endometriosis. Oh, this is the same patient. So yeah, you definitely need to find a doctor who takes who can excise endo. She mentioned something about Medi-Cal. So, you know, lots of times there's excision docs who work at major medical centers who are excision docs. I don't know who takes what insurance, but start with Nancy's Nook and take a look on there, and then you can see, you know, based on, you know, who takes what insurance. But I promise you, you will have more pain if you go in and remove your uterus and leave that endo there than you have now. Were there any other? I'm looking for, what is that? A physical therapist. What do I ask for? Okay, I think from a PT perspective, you can probably answer that better than me. You know, you don't want to go to a physical therapist who does shoulders and knees and car accidents. You want someone who specializes in pelvic floor, but you can speak to that much more than me.
Yeah, so with trying to find a pelvic floor physical therapist, I think Dr. Orbuch hit it on the nail where you want to be able to find someone who specifically treats pelvic floor disorders and evaluates the pelvic floor, able to do an internal as well as external exam, because with pelvic floor physical therapy, it's similar to, you know, if you go to physical therapy for your knee, we're looking at how good your body is moving, your strength and all that. But as pelvic floor physical therapists, we have a little bit more training in evaluating the pelvic floor muscles internally, but also correlating it with your bowel, bladder, sexual function symptoms, as well as overall quality of life and movement mechanics, with how something like endometriosis could also affect the way you move day in and day out, and overall body awareness with the pelvic floor as it relates to the other muscles in your body, where that plays a role in how to consider the pelvic floor as just as equal of a team player as the rest of your body. So overall, I would say when looking for a pelvic floor physical therapist, you want to find someone or a group who specializes in pelvic floor physical therapy, and going from there.
Great.
Dr. Orbuch, I think there's another question. Oh,
I think Jenny answered it.
Anything else? And Jenny, do you have anything else that you want to end with or share?
Hello, hello. No, I think that was great. I really appreciate both of your time and giving some good answers and really promoting more of that holistic recovery, preparation for surgery and recovery from surgery, because it's just very refreshing to see someone that also just understands the impact of nutrition and meditation and exercise and sleep and social support and all those kind of general health pillars that we talk to our patients about trying to optimize their journey to recovery. So
I think everyone needs, whether you have endo, any autoimmune disease, anyone has irritable bowel syndrome, constipation, diarrhea, you need to really, I think the gut is the brain of the body, honestly, and we need to address the gut, we need to address the mind, and that's the first thing that I think the whole world needs it.
especially after the year we've had, right?
Yeah.
Excellent. Well, thank you guys so much.
Thank you for having me on, and happy Endo Awareness Month to you all. Okay. Erica, best of luck. Okay. She was the one asking the questions. Okay. Yep. Take care.
Bye.